Hello, my name is Dave Arnold. I'm the Executive Director of NextGen Precision Health, the initiative. So I would like to welcome everybody to this month's Discovery Series. It is my pleasure to welcome Dr. Ko, who is a double-boarded surgeon scientist whose clinical work focuses on colorectal cancer. He's a professor of surgery at UCLA and has published over 400 articles. He also serves a dual purpose, so he splits his time between California and Chicago. He serves at the American College of Surgeons as the director of the Division of Research and Optimal Patient Care, as well as the director of the National Surgical Quality Improvement Program. So I'm going to hand over the stage to Dr. Ko. He's going to talk about improving improvement, generalizable lessons of improvement from surgery. And then in this talk, he will discuss the successes and challenges of healthcare improvement and how hard that is and lessons that he's learned during his work. Please welcome Dr. Ko.
Great. Thank you so much. Can everyone hear me okay? Okay, perfect. Well, thank you, and I hope everyone's enjoying their lunch. And what I would like to talk to you this morning about is about improvement. And when I was thrilled to be invited to talk in this NextGen Discovery Series, because I think that probably over the next 10 years, we will make huge advances in healthcare. The amount that is being done kind of on the preclinical scientific side is amazing. The amount of informatics that we're able to do with, ChatGPT and generative AI is amazing. The amount of integration in our healthcare system is really also amazing. And the need for all of this work is really more than ever is needed right now. We have unwarranted variation in care. And so not you wearing your hat as a leader, thought leader in research, but you wearing your hat as a potential consumer of healthcare, when you have to see your doctor, your neighbor, your family. How are we doing as a healthcare system? And I don't know if anyone has graded it, but we're probably not doing very well. Certainly if the grade is that nobody would get into medical school with those types of grades, or any school for that matter. And so this is a really ripe time to advance in what we're doing. And as we advance in what we're doing, and so something is discovered, and this is what we're all here to do in this building, on this campus, is to discover things that are going to advance our care. We have to really think about, all right, once something is discovered, once we have this solution, how does it really get put into improvement? How does it get put into our healthcare system? And, a fallacy is that, well, it's the right thing to do. Of course, everyone will do it. And you have probably some experience in that, just that when we see the right thing to do, it's still done 50% of the time. And that's what studies show, that when we have the right answer, it's still only done 50% of the time at best. And the where it's done and where it's not done has led to what you've seen across the country in disparities of care and the have and have-nots and the systems that have and have-nots. And so how do we, when you all advance science and bring something to the real world and have an answer, how does that get put into play in our world? We think about when we develop something, we want validity, right? We want whatever is being developed to be the right thing to do, that it really works. And so when we have a randomized controlled trial, we are really looking at internal validity, that whatever we develop, a medication, a process, a way of doing something, a material, that it is valid. It has internal validity for making something better. What we need to have also is external validity. We need to know that it works here at MU. We need to know it works here where I work at UCLA. We need to know it works at some rural hospital up 100 miles from here, north or south. It needs to work in this whole apple core of Missouri and all the states surrounding it, in the country, and perhaps the world. That context of the way things put into play is a large problem in this country because our system is disjointed. We have non-coordination. Excuse me. We don't really know how things work well in a complex situation. So I'm going to talk about how we give care, how we evaluate care, how we improve care. And improvement, whether it's in healthcare or you want to improve, how you make, your kids do something or your pet not pee on the carpet or anything like that. It's really about change. And most people hate change. And so in this, when you develop something and when out of this great institute here, if something is developed, how do you get people to change and take in what this is, and how do we do those types of things? So, improvement, generalizable lessons, and I happen to be a surgeon. I work with surgeons, for surgeons. So I'll give you examples here, but I think that the external validity of this goes way beyond surgery, and it might be how you fix your toilet at home, or how you get a new washing machine, or figure out a better way of going to work. So I'm going to talk about these 4 things. We need definitions. We need to have understanding. We need to have terminology. And so if you do work in this, and if you were studied linguistics or another language, we need to have a common language. We need definitions. And the word that we have now in healthcare is value. And value is quality over cost. And what we need to do, and especially what you all are doing in advancing our knowledge and advancing care, is what is the numerator, what is the quality metric that is going to change based on what you are developing. The next thing is the context of simple, complicated, and complex. It's a very important thing. And I see some people in the room who were here earlier when I spoke to the surgeons. I wrote this talk first, and I'm like, this is really important. So I gave very similar ideas to the surgeons. So if you are in this room and heard this talk this morning, it's going to be largely the same. But really, this talk was put together for you all in NextGen. Then the third thing will be a fix. When you have a fix and you're trying to fix something, you're trying to implement something, you're trying to change something, what is the best way to change something? What do you just tell people to change? I'm a surgeon. I believe everyone should listen to me, but most people don't. I'll bring a pizza into a conference room and try to get people, I'll bribe people with a pizza. It usually doesn't work. I'll ask our C-suite to kind of pay everyone some extra money, incentivize them. That works for a little while, but then it falls. How do we get change to happen, especially in a complex situation? And then the 4th thing is that how do we improve improvement? However, and it's basically how do we change better? How do we do change management better? So let me talk about those. The first thing is the notion of value. The notion of value abounds. It's everywhere you see, whether it's the value of something you buy at Sam's or Costco, or the value of healthcare, or the value of this car that you buy, of electric cars or whatnot. And it's the numerator. The numerator is where we need to focus. So value equals quality over cost. And as healthcare becomes more expensive, and it is getting more expensive, value-based care is increasingly in the front and center. Everyone's talking about value. And unless we do something, unless you all do something to improve quality, we are just going to focus on cost. And it's going to be, how do we decrease costs increasingly more? And cheaper care is usually not always better care. And so how do we do those things? Price transparency, for those of you who know, price transparency is increasing, so we are constantly getting to know more and more about how much things cost. How much does this pill cost? How much medication cost? How much is it going to be cost to get this operation done? What is the hospital going to cost? The OR going to cost? Seeing my doctor? All these things are going to be known. So if we know cost and we know the denominator, we have to know what the numerator is. And for the clinicians in the room, or the people who work with clinicians on the team, it's what clinicians do is really focus on quality. It's what we uniquely know. I don't know if there are any MBAs in the room, but the MBAs have studied business, and they've studied the cost, they study the finances, they have the great spreadsheets and pro formas. They don't necessarily know the quality in a way that the providers and the clinicians do. And preserving the focus on quality is paramount. it keeps it from being relegated. And a lot of kind of people in healthcare think it's relegated to something below cost. And so we need to continually achieve higher quality, and it should be the focus. What should the numerator be? So if you think about quality, and if you think about the last time you went to the doctor, or somebody in your family went to the doctor, if anyone ever had surgery or needed that, what is good quality care? What is good quality surgery? Well, there is this acronym called STEEP, and here are the things that we would want our care to be. If you have surgery for a hernia, or somebody in your family had colon cancer and needed to have their colon out, you want it to be safe, free of complications. You want it to be timely. You want to see the doctor, if you're diagnosed with cancer, you want to see them in the next couple days rather than the next couple months. You want it to be effective. So if you have surgery for cancer, you want to have that cancer cured. If you have cancer, if you have surgery and chemotherapy, you want to have that thing cured in the effectiveness. Efficient, you want it to be, if I come into the hospital for a CT scan and a blood draw and see my oncologist, I want it to be in the same day and not 3 consecutive days. Equitable, we have to, whether I'm old or young or rich or poor or anything like that, it should be the same, and it should be patient-centered. I have pain. When my patient has pain and I say, well, I cured your cancer, and they say, well, I have pain, I should deal with their pain as well as trying to cure their cancer. So the patient-centeredness is really important. I suspect a lot of you are working on things that are really important to the disease process, and I suspect a lot of you are also working on things that are very important to the patient. And we need to kind of marry all those things, and if you have high quality, you should have each of these domains set off and be in the green box rather than the yellow or the red box. So these are the numerator. We collectively need to define it. We, the healthcare providers, we, the kind of the financiers of the healthcare, we, the patients, the stakeholders, we all need to define these things. And then our healthcare system or our local system, me at UCLA, here at MU, need to help support how we're going to identify these things. So that's quality, and that's what the numerator is, and when we're talking about value. Now, a lot of times, whatever you're developing, whatever you're advancing, whatever you're discussing and discovering, the concept of simple, complicated, and complex relates to what we do. And largely, if you are working in a very advanced disease that needs a lot of help, it's going to be very complex. And most simple things are simple, and we've already figured out how to do the simple, but the complex isn't as easy to figure out. And so this concept is really important and for the work that you do, but it's also important for the way we live our daily lives. So simple, one-to-one, you kind of cause and effect, you do something, you get an effect, and it's reliable, and that's kind of the first one, the straight line. Complicated is a little more loopy, and it's a little not as easy to follow, and that's complicated. Complex is that it's really, really loopy, and there's some parts in the middle of it that you don't see, so you don't exactly know what's going on, so there's some level of unpredictability. You can't predict everything. The outcome is not always known, and that's how complex is defined. If you think about this, some examples, simple is baking a cake, so you just there's a recipe that you follow. Complicated is something like sending a rocket to the moon, where it's not 10 easy steps of baking a cake. I've never baked a cake, but I assume it's about 10 steps. But sending a rocket to the moon is going to be way more than that. And then complex is raising a child. And so there's a lot of steps in that. In simple, baking a cake, the protocol is essential. The recipe is really important, and follow the recipe, you'll get a cake. In complicated, sending a rocket to the moon, there are some protocols and formulas like that gravity formula of how you send the rocket off, and there's the thrusters and the fuel that you need. There's the kind of trajectory. You have to figure out where the moon is. You don't want to miss the moon when you're trying to go there. And so there's a lot of things that come into play, but it is doable, and we've already proven that we can do it, but it is complicated. You just can't figure that out. I certainly wouldn't be able to figure that out. Complex, raising a child, there are protocols that have been put out for raising a child, and they may help, or they may be detrimental. And so this is the simple, complicated, and complex. Recipes are tested for baking a cake, for sending a rocket to the moon. One success will help you with the next success, but it doesn't guarantee it, but it definitely helps. And raising a child, if you have more than one child or more than one dog, the fact that you do it well with one is no guarantee that the second one will be the same, better, or you'll get the same results. So that's the level of complexity. In simple, if you're developing something that it only takes one person to do it, like the baker, you have a really good baker, you're going to have a really good cake. If you have something that's complex and you have a really good surgeon, but the patient is really sick and whatever, and we do the perfect operation, there's still a lot of things that are unpredictable because of comorbidities, because they have diabetes, because all these other things. And so complexity requires responsiveness and adaptability, and it's not as set. Simple is every project is identical. And in complexity, every project is pretty unique. The settings are unique and so forth. And so again, when you're developing something and it's going to be a one-off, 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 and you see one, you see one, it's not you see one, you've seen them all. That's what more complexity is. And again, in the simple, outcomes are guaranteed. You follow the recipe, you're going to make a good cake. And in complex, there's uncertainty in the outcomes. You don't know what's really going to happen. And it's a continuum where in simple, you have high agreement what to do. You have to use flour, eggs, you use a pan, you put it in the oven, there's agreement. And the certainty is pretty high that you're going to get a cake at the end of the day. Something that is raising a child, the agreement is lower. There's not always agreement in how to raise a child or get your dog to be potty trained. I'm still trying. And certainty is lower. Oh God, I'm just praying that I go home and the carpet is not stained. And so that is the continuum of simple, complicated, and complex. Things that are simple are less complicated. There are things that are highly complicated and complex. And the key ideas for simple is that you want to standardize things. You want to have reliability and have high quality is achievable. So if you, again, are developing something for something in the simple world, you're going to get to high level of reliability and achievability. Whereas if you go into something that's complex, no matter what you develop, if it's a complex system that you're putting it into, there might be some level of unpredictability, real-time monitoring is needed, adaptation and interdependence. So if you think about, again, the validity of what you are developing might be totally there in spades. The feasibility of putting it in and implementing it, depending on the system that you're going to implement it into, if it's complex, there's a huge amount of work that has to be understood when you're putting something into a complex situation. So if you develop something to help raise kids or stop dogs from peeing on the carpet, there's that level of unpredictability of the individual agency that your child has or that your dog may or may not have. And so this is the hard part about the curve, is the highly complicated and complex areas where, again, the fallacy is that if we think it's the right thing to do, how many people actually do the right thing? Less than 50%. Achieving quality in this end is the continuum is more difficult. There's variability, there's unpredictability. And in healthcare, it's the disease factors. There's a spectrum of the disease, and we don't always understand everything about the disease. There's the patient factors where the patient could have 10, 15, 20 different comorbidities that is going to affect potentially the medication that we give or the surgery that we do or the process that we do. And then there's facility factors of just kind of putting it into that setting. That all leads to the complexity. How do we reliably achieve high quality when things are complicated and complex? And so in surgery, and if you think about the surgery, there are 50 million procedures that are done in the United States each year. And there are some surgeries that are done that we would say are complex. The disease is complex, the patient coming in is unique, and the patient is complex. The setting may or may not be set up to this, but how would we in this country address the complexity and ensure that the quality is high. And how, when you all are developing something and discovering something and putting something together that we would put in that's going to help this level of complexity, how would we ensure that whether it's here at MU or whether it's in St. Louis or in Kansas City, or any place in between, how would we ensure complexity in care is done well? And so that's the problem we had. And so what we call programmatic quality, or something that has resources, processes, and outcome metrics, is how we've really tried to tackle complexity in what is happening on the front lines. Resources, processes, and outcome metrics. So I'm not sure anyone in this room has ever heard of this qualitologist, this professor who was at Harvard and then went to Michigan, Donna Bedian, but he has a quality model: structure, process, and outcomes. So structure is the resources, the physical and personnel that occurs in a place. So in the hospital across the street, resources include things like a CT scanner. They have a clinic space. They have people there. They have experts in surgery. They have experts in chemotherapy. They have experts who have knowledge and expertise and experience in things. They also have, probably the most important resource is time. They are given time to kind of see a patient, to kind of meet with each other, to kind of do the things that need to be done. And that's structural pieces. We know that a place that has no CT scan and no MRI, or if you discover something and that hospital doesn't put it into play, not going to be as good. Structure is really, really important. Process is what we do. So we know that if we give antibiotics before a case, the infection rate goes down. So it's the right thing to do is to give antibiotics before a case. We know that, for example, in cancers that I treat, a stage 3 colon cancer, if we give the right chemotherapy to that patient, their survival is better. So effectiveness. So doing the right thing is also important. We know that if we have the right people, they're more likely to do the right process. So structure and process has a relationship there. And if we have the right people doing the right thing, there's more likely to have better outcomes. So again, NextGen, developing these things. What is needed in terms of structure? What is needed in terms of process to get to the outcome you want? And again, the outcome are those 6 things in STEEP that we're all looking at. And as you develop these things, what are the STEEP things that your discovery, your invention, your kind of piece that's going to add advanced science is going to add to healthcare, and how do we put it into play? So the College of Surgeons, don't worry about this. We have a lot of different programs that address complexity and highly complicated care. And this is very similar to, if you kind of read the business literature, there's a very famous kind of business professor who just recently retired at Harvard. His name is Michael Porter. And if you went to business school, you've heard about the 5 forces of companies and kind of what makes a company successful or not. And then he said, all right, I'm going to finish the 5 forces and I'm going to work on healthcare. So the last part of his career, he worked on healthcare. And he felt that the best way to get high-level quality care is through what he calls IPUs, integrated practice units. And integrated practice units are basically what Donna Bedian said: structure, process, and outcomes. So 2 very smart people are coming down to the same strategy of getting improvement and change and high reliability in complex situations, and it's really structure, process, and outcomes. And I won't read this for you, but it's basically saying those types of things. The American College of Surgeons, where I work, we do quality improvement programs, and we try to address in the country where there's complex care and it's done really variably. Some places done well, some places not done well. And so our strategy has been to follow what Michael Porter and what Donna Bedian has said, is to identify the structure and processes that we want to have in place to ensure that we get outcomes. And so when you look at these manuals, and these are just some examples of the manuals, they set down standards that address to say that you need these structures at your place if you're going to be a trauma center. You need to have an ED. You need to have a CT scan that's always available. You need to have an ICU with structural, with experts in the ICU who know what they're doing. You need to do the right processes. You need to have a protocol to get from the ED or from the helicopter to the ED. The ED kind of figure out where the problems are and then go to either the operating room or go to the ICU or whatever. You need to have those protocols in place. So you need to have structure and process, and then from those we think that the outcomes are going to be better. So we have standards, we have the right foundational pieces of the structural pieces, we have data and outcomes to see where things are getting better or where there's opportunity to get better. And then the last part is verification. The company I work for, the American College of Surgeons, goes to these example trauma centers every 3 years to make sure the standards are being upheld. And then when they are upheld, that place is, for example, a level 1 trauma center. So you've all heard about level 1 trauma centers. This is the thinking behind a level 1 trauma center. MU is a level 1 trauma center. So I'm going to give you an example. Does this program work in the face of complexity of a trauma patient? Trauma patient, whether it's a car crash and all the things that can go bad in a car crash, it's a gunshot wound, a stab, a fall, or anything like that. Does a level 1 trauma center that has these things in place do better with these things? So again, this is the manual that has all the standards, and I can tell you right now, MU is preparing for their next accreditation visit with all of these, and people are working really hard to prepare for that visit. This is a paper that was published in the New England Journal of Medicine that evaluated trauma care in trauma centers versus a non-trauma center. The trauma centers have the standards in place, so the structure, process, and outcomes. A non-trauma center is just like, yeah, we can take care of this sick patient, this stab wound and whatever, however, and we'll just do what needs to be done. Organized care, structure, process, and outcomes versus we'll figure it out. And so if you look at this, and it might be hard to see, but the first green box is the overall population of trauma center and a non-trauma center. You can see that a non-trauma center does worse. The trauma center has a lower mortality rate, which is a great outcome metric for people who are very much injured in a trauma accident. So they do better. If you look at the lower green box for maximal AIS, basically the maximal injury severity, the difference is even better. So if you have somebody who is in a car accident, or you see somebody who was shot, if you want them to do well, have the best chance of doing well, you would put them into a trauma center that follows the standards of structure, process, and outcomes. If you think about bariatric surgery as another complex disease, because these patients are high-risk patients, that 10 years ago, the mortality rate of these was about 7%, which is really high for an elective procedure. You don't want the mortality rate to be that for an elective procedure that we're not doing on an emergency basis. And basically what it shows is that there's an increased mortality if it's a non-center of excellence, so places that are doing bariatric surgery, weight loss surgery, that do not follow standards of structure, process, and look at their outcomes do worse. In the box to the lower left, it shows that they are more expensive, they have more complications, they have higher mortality, and FDR is failure to rescue in places that do not have standards, that do not follow those things. So again, we have an answer for complexity, and it's putting these things into play. Breast cancer is a very difficult disease, and this is my third example in this of a programmatic way of looking at this. Breast cancer requires diagnosis, very difficult to kind of detect all these things with the screening. It requires sometimes surgery, it requires chemotherapy, it requires radiation, it requires sometimes more chemotherapy, it requires all of these things in an integrated way. You can imagine that somebody lives in a rural area and like how are they going to get all these things coordinated? It's very complex. There's a lot of unpredictability, schedules, agency of the individuals. And this will be a hard thing to find, but there are performance metrics, like if somebody It has a positive hormone receptibility in some of the receptors for cancer. It's better to give certain chemotherapies, tamoxifen or an aromatase inhibitor. The next one is if they're hormone receptor negative, it's better if they get chemotherapy or whatnot. And what this graph shows, everything in the circle, is that places that are a center of excellence and that follow these standards do better. If a place has the structure in place, the processes in place, they will do better in the outcomes. Excuse me. So, programmatic quality strategy works. Structure, process, and outcomes. When you're developing these things, you want to put it into a program. We're asked by the government, CMS, Medicare, to develop a performance metric. And instead of just an outcome metric like mortality or readmission or cost, we developed a metric that has structure, process, and outcomes in it. And the landscape has identified that this is a much better way of doing things. It is proven to work for complex care. It is proven to work for complicated and simple. So this is kind of the way probably things are going to go. So the last step of this, and then in the last 10 minutes, I do want to talk about improvement. And when I use the word improvement, what I mean is change. Everyone hates change. Nobody wants to change. And so the importance of well-conducted improvement for achieving high quality. So there's a relationship when you think about what you do in terms of care, evaluation, and improvement. And this is the relationship here. Your doctor or you give care. You give chemotherapy. You conduct surgery. You read a scan. You give care. We have to evaluate how that care is. We have to measure. We have to use metrics. It's like, all right, you did surgery. Did you do well? Is your infection rate high? Did you cure that cancer? Did you fix that hernia? Did you replace that hip and the person can walk? We have to evaluate it. The evaluation will tell us where we're doing well and we're not doing well. When we're not doing well or as well as we want to do, then we need to do the improvement. So this cycle is really, really important. When you are developing something and it should go into the play of care, we need to evaluate it, and then we need to improve it if it's not ideal. So care, evaluation, improvement. We looked at how well improvement is occurring in healthcare, and we looked at surgery. We looked at 50 different improvement efforts that are being conducted in trauma, in children's surgery, in bariatric surgery, in all types of surgeries. And basically, these were done in all types of hospitals, all types of settings, teaching, non-teaching, academic, non-academic. Most of these things address safety issues of quality, and most of them were to kind of standardize how we do things. All really good. What the problem was that the average score of the way these things were being done was 39%. They did not do well, and if you look at each of these projects, each of these lines show the score of how well the project was conducted. We want 100, right? Probably everyone in this room is an overachiever, so you want 99 or 100. The average score was a 39%. The way people are conducting change, the way people are trying to conduct improvement was really terrible, and this is on the front lines. So if you develop something really terrific, you want to put it into play, you will hope that people are doing better than a 39% in terms of putting it into play and getting to change. This poor improvement isn't new, and so people have talked about something called PDSA, Plan, Do, Study, Act. I don't know if anyone has ever heard of that, but it's a very common acronym that we use in healthcare to do something, to change something. We plan something, we do it, we study it, we act on that, and we kind of follow that cycle. And this basically, this review of how these are done across the world is that 85% of these are not doing these things appropriately. So again, when you are trying to do something, you want it to be done well. And what this shows is that when improvement projects are better conducted, they're more likely to be successful. If you do a good job at what you're doing, you're more likely to be successful. If you do a poor job, or you're trying to implement this into a hospital or into a system or onto a floor or into an ICU, if it's not conducted well, it's less likely to be successful. And then when things are, and if you have it's a long shot when it doesn't have to be, you're just wasting time, effort, energy, goodwill of the people, and then people are less reticent to do it the next time. So this is really important stuff that we want the efforts to be well conducted. So we really need to improve improvement. The current work we're doing to improve improvement, and I think that as I've seen a lot of folks do this, we want validity and feasibility, that we want to make things really feasible. We want to make things really easy to understand. We want to communicate it well, and we want it to be easy to do. And so what we've kind of understood is that we want to simplify improvement. We want to really work on the front end pieces of improvement, which is kind of the planning piece. Because if you plan something well, then the trajectory works in a much better way. And this makes so much sense. However, when we follow these things, when we watch these things on the front lines now, there's not enough planning, and people just go right to kind of getting their feet wet, kind of jumping in, and kind of flying by the seat of the pants. And so probably to you all, this makes a lot of sense, but when this happens on the front lines, it doesn't. And so screening, problem detailing, aims, and mapping out, I won't go into this because this is probably not as relevant for you, but this is probably more relevant if you're going to do this not in healthcare, but kind of in your own lives. You're going to figure out how you're going to fix your car, or whatever. Kind of doing all these things is really important. So I'm going to end here, and here's some summary thoughts. And this is all relevant, and I really kind of thought about this as thinking about talking to this audience of people that are in NextGen and discovering things. We really need to define value and really to address validity and feasibility. When you are developing something in whatever lab you're working in and whatever team you're on, is it valid? Is it actually fixing something? What is it fixing within the quality definition of STEEP? And how feasible is it to put into play? And there's so many things that are developed that are not feasible. I've developed things that are really valid, but not very feasible, and it never gets used. It never gets put into play. And so thinking about that is really important. Looking at simple to the complex continuum needs to be understood at the outset. And whatever is being developed, what kind of context is it being put into play? Is it, if it's something that is complex, that's going to be very different than if it's something simple. And how do you get it to be used and used effectively is really, really important. Programmatic quality. So hopefully you've kind of been introduced to this idea, or you probably knew it already, and then kind of supported that having just structure, process cannot be talked about enough and emphasized enough that these are the things that make things work. We want always something to be done yesterday and just change that outcome, but we need structure and process in place, and having that all set up and planned for first will help to achieve things in a complex setting. And finally, improvement, which includes change management and implementation science principles. I was talking to the dean that a new faculty member has come who's an implementation science expert, which is great for MU because improvement and change management and implementation are really difficult, but these are the essential things that because no matter what is developed, if it's not implemented, it's not put into play, and with high fidelity, it's not really going to work as well as it should be. So these are some of the things that thinking of kind of short, medium, and long game of what you all are doing, which is, when I looked at kind of the list of things, is really amazing and exciting. And so I just try to add on to that in saying that to get it into the real world and the front lines and really impacting STEEP of quality all of those things, it's really important to think about kind of the continuum of how this all works. So I'm going to end here. Thank you very much. Oh, this is how we kind of look at hospitals. And this is may or may not be, but what you want to think about. When we look at improvement, there are some hospitals that are in the red that kind of get better, worse, better, worse, better, worse, and they don't really pay attention. There are some hospitals that are like the yellow that kind of do things the same way all the time, and they don't change. There are then the hospitals that are the green where they continue to have improvement, where they standardize, they innovate, they standardize, they innovate, and they get better and better, and they build, 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 build. And this is not just true for hospitals. This is true for teams, whether it's the team that's on an F1 car kind of company, or if it's a team on the baseball field or whatever, that you're constantly building on these things and building the knowledge, building the experience, building the implementation of all these things. And I'm sure kind of in your labs it's kind of the same way. But there are definitely, and most of the hospitals are unfortunately the red and the yellow when we visit them, and it's the special ones that are to the green. And so hopefully some of the things that you will be developing are the ones that are going to help these hospitals all become in the green hospitals. So I'm going to end here. Thank you very much. Thank you for the invitation to come. Happy to answer any questions.
Thank you. Chartice Jones, Department of Mathematics here at the university. Well, I think that in my research that I am doing, I'm finding that instead of actually looking into the actual institution, it is vital that we start looking into those personnel inside the institutions. Because only then will we truly be able to, because you have noted that, well, even when presented with the right answer, the individual will still make a less than appropriate or proficient decision. So now we have to not question the institutions or the practices at the institutions, but the individual that are actually implementing that particular practice or made that decision, because even when the information is right, a decision is wrong, right? So why was that decision made is where we should start our practice. Instead of looking at the institutions, how are we investigating the practice for hiring, and how are those personnels performing in those jobs is how we should investigate. And because that's what I'm looking at as a driving parameter in the research instead of just the institution. I'm removing the institution as a major factor, and I'm putting the individuals as parameters within the models to investigate how that changes the actual surgical outcomes in the clinical research.
Yeah, so just to add on to that, absolutely, things are nested within each other. So within an institution, you have your individuals. If they are simple things, it's going to be based on, so in the hospital cafeteria, the baker who bakes the cake follows the recipe, and if that person doesn't follow the recipe, we're screwed. We're not going to have good cakes. Certain complexities of, in the same hospital where you have the trauma service and you have all the disciplines that are taking care of the trauma patient, there are individuals in there, but what the trauma service does is to ensure that the individuals know the protocols to get to the good outcome. So it is about the individual, so you're absolutely right. And it's all nested within the organization.
Thanks, Dr. Coe. That was great. And thanks for giving a plug to Dr. Ann Sales, our implementation science guru. So please, all of you who have got projects that you might think could be at this stage of implementation science, contact Dr. Sales in School of Medicine and School of Nursing. So you mentioned in your slide, better conducted improvement projects lead to better results. How do you define better conducted? And I was thinking about that as I was just looking at a review I got on one of my randomized controlled trials with my team, and the reviewers tore it up because poorly conducted. And so they have ideas in their head on what a good and a bad conducted randomized controlled trial is. That's what gets it accepted or not. How do you do that in the quality world? What's the definition?
Great question. So maybe a good way to think about this is project management. It doesn't have to be quality improvement. It could be project management. So a project man, if you want to have a good project underway to build a table or whatnot, you need to have the right people around the table. You have to have the right, usually for a project, you're trying to implement something, you're trying to change something, you're trying to do something. For quality improvement, it is about improving a problem. So part of a quality improvement project is to, number one, understand what the problem is. What is the scope of the problem? What is the effect of the problem? How are we measuring the problem? So that if we're going to do something, we know in a pre-post, afterwards, is the problem fixed? So that's one thing. Who are the stakeholders? A lot of times we have downstream effects of what we do, and we don't know that it's going to affect another part of the hospital. So understanding all of those things is studying the problem and getting the input of the people. So those are two things: problem, stakeholders, there's the resources of doing these things, there's the expertise of that. And so those are a well-conducted project in kind of the, and I very quickly went through these, probably too quickly, is how do you start a project well before you start acting on it? It's a lot of those things. A poorly conducted project is like, that's a problem, we know it's a problem, let's just do something. Let's just give antibiotics. And like, well, that problem wasn't, about antibiotics. It was about, did we wash the body? Did we kind of use sterile instruments? Do we have something else like that? And so a well-conducted project has a lot of thought put into it in the planning, which we don't do well. And then the implement is identifying the intervention. So if it's an infection problem, is it the fact that we don't have, I was talking about this with some of the experts that are leading the improvement efforts, the quality efforts at MU. If it's an infection problem, is it because we're not giving antibiotics? Is it because we're giving the wrong antibiotic? Is it because we're not using sterile instruments? Is it because the room is too cold and then we know infections are higher? Is it because we have the wrong person putting in the urinary catheter who is causing the infection? Is it any of these things? Is it a combination of these things? So we have to, then in the planning, we have to identify what's our intervention. We have to identify how to implement it. Do we put it into every operating room and have everyone angry at us? Do we start with one and then scale it? Do we just do we pay people to do it? Because the dean has endless money, so the dean can say, yeah, I'm just kidding. Do we incentivize people with that, a piece of candy, a pizza, or just kind of knowing it's the right thing to do? What data do we use? And so those are components of what a well-conducted project is. We had 10 components in that paper, and that's what led us to doing them terribly.
There is a playbook for this, and it's in your documents.
Yeah.
Question online that might continue on that thought process, but how do programmatic efforts impact the learning curve of various surgical procedures?
Yeah, so, I'm glad I have this slide up. As we figure things out, as we put in a program, we're always constantly, and I said there's data in there, we're always constantly identifying with data opportunities, problems for which opportunities to improve are. And so whether that's the surgical procedure, whether that's the team working together, whether it's some other process, whether it's a structural thing, getting data to kind of understand where we are, to identify the problems will lead us to getting better. And it is sometimes the surgical procedure. We need to throw a different stitch. We need to kind of have a different process of kind of in the operating room. We need to use the robot instead of some other way. So that leads to all of those things to evaluate. Great question online. Thank you.
Thank you very much. That was really fantastic talk for a basic scientist like myself. Really appreciate this. I guess really my question is that you presented a very nice recipe, how do things right in an effective manner. And my question to you, when I look at this curve, I look at green and then yellow, what is the difference between the two? Because the yellow doesn't have that recipe, or simply the yellow doesn't actually follow that? And if it's doesn't have recipe, how we could actually provide a recipe? Especially when it comes to healthcare, we're talking about, impact on the life of an individual. Thank you.
Great question. So why are all the yellow hospitals yellow and they're not turning to green? I think that the biggest factor are people. How much, if you get data fed back to you, how many people act on that data versus not act on that data. If you show that your infection rate should be 4% and it's 7%, is that worthwhile I should act on that? Or we think, oh, that's just a blip, it always happens in January, in February it'll go down. And so a lot of times the decision to act on something is very much a human factor decision. And so most things, even though we depend on technology, it's the humans that use the technology, and I think it's individual kind of, and also leadership decision making of what we act on and what we don't.
Yeah, so that I can appreciate that. I guess my question is more what you just presented. This is basically information being validated. The question is that even in a healthcare system, the leadership, is it aware of that knowledge? Is that knowledge available to the leadership so at least they can improve it? I think that's my question. For example, this lecture, what you're presenting, how many institutions are aware of what you just presented today?
I think that it's a hard question. That is a hard question. It's a great question.
Can I say something? May I say something, please?
Sure.
What I am finding is not that they don't have the information and they're not trying to digest the information. It is the lingo in which the words that they use. Some of the words they don't understand, and some of the people are not native to certain regions and they don't understand the communication. It's not that they're not reading or not trying, but the way they are putting the words together, the of before the direction, things like the preposition, the phrase, the object, the preposition, the direct object. What does those things mean in the sentence? And that's what they don't understand. It's the language comprehension that is being lost when I go through the data in the clinical information. And that's why I was saying what I'm saying, because I'm trying to move race and gender and ethnicity as factors and look at things like velocity, diameters, and radius of vessels and stuff instead of the individual. That's how I am looking at it, and that's what I am continually finding, that it's not the person, it is how the things are written, and they're moving into different spaces, and the clinical technicians are not mathematicians, so the mathematicians wouldn't be able to understand exactly what the clinicians are saying unless they go and do a deeper dive into the lingo of the clinicians, and that's how they get a better understanding. So we need to adjust and include a learning curve in all spaces so that when information is brought, it can be digestible, bite-sized digestible for the person.
So I think another answer to your question, building on that, is organizational management, whether it's the organization of this institute or the organization of the hospital, organization of the trauma service, is variable. And the decision of leadership or kind of the front lines or kind of that vertical integration of an organization will dictate how green or yellow a place is. And how aggressive, risk adverse, or anywhere in between an organization is will dictate those things. And I think that as we look at hospitals that are kind of like have nothing to lose because they're so bad, they're much more risky. As they get, and they start making money and they start getting famous, they're much more obviously risk adverse, and that's when they start to get more of the yellow than the green. So a lot of factors go into that. And it is a great question, and then people have different experiences. Like I've always decided to bet on the sure thing. Which would have been, I guess, Kansas City instead of San Francisco. I don't know, but that type of thing, and so many factors go into that. Great question.
Dan Walker. I'm from the School of Medicine Department of Pathology and Anatomic Sciences. I couldn't let the previous commenter's comment go because it touches too close to home, and I was going to ask about the Maverick effect, but the commenter beforehand kind of addressed that. I just got done with a multidisciplinary council where I got a consensus among the surgeons to practice it a certain way, and immediately in the next 2 weeks I had one surgeon that decided they're going to practice the old way, and then when they pointed out what the change has been, they said, well, I'll think about it. Well, that's the maverick effect, and it's very frustrating. And I don't know how. Again, I want to bring it back. How do you overcome that personal effect? That individual who doesn't want to change, that says the quality system is what I'm doing right now and not what everybody else is doing.
Yeah. So it's hard, and surgeons are, being a surgeon, working with surgeons are very difficult to work with, and so. There's two kind of quick answers. Data is, if it's my opinion, it's my opinion versus somebody else's opinion. If it's data and objective data, which gets to the metrics and gets to the steep and gets to those things, those are a lot less arguable. And then there's the other piece of culture. So the other word, data and culture. What is the culture of the team? Are people open to trying things, open to kind of other ways than their own? Are they open to consensus? And consensus is, everyone has a different definition of consensus, like we all have to agree on something. And that usually never works. What we have come to for a lot of more advanced, sophisticated organizations, teams, whatever you want to call it, is the consensus is that we agree that we will come to a set way of doing something, even if I don't like the idea. I agree that we are going to share what we know, and then we are going to do something in a standardized way for these surgeons. So there are 7 colorectal surgeons at UCLA. We never agree. We always argue. We never agree on anything. But what we have come to is the culture that, all right, I believe it's this antibiotic and somebody else believes it's something else or whatever. We all have agreed to say that we are going to try for the next 2 months to use this one antibiotic. I think it's wrong, but in this consensus and the culture of a team is that we will kind of do it in the same way. When we have a maverick, that person is detrimental to the team. And whether, you've seen this in movies, you've seen these in books, 5 Dysfunctions of a Team, which is a really great book where sometimes those mavericks have to be punished, let go, whatever from that decision-making process.
Right.
Well, the maverick always did data right.
No, but in actuality, even if there's a situation where the maverick is right, well, what happens then if the maverick is right?
So part of that is getting the team to say that, all right, if we agree that whatever the maverick says, we're going to do that, fine. If the whole team agrees that, that's not right because you're using 1950s science,
Even though the data says it's right.
well, if the data show that, then that's it. But usually these things come to play where it's very personal and there's no data to support those things.
Fantastic to have a really healthy discussion and tons of questions. Really excited. I have several I would love to be able to ask. But before, I may give you one short question, but before I do that, I want to plug next month we have Arthur Burgess who's going to talk on a disease, spinal muscular atrophy. And this kind of actually feeds into my question. So he was a key player in the development of a therapy that took a universally fatal disease, usually by about 10 months of age, and now these children are being treated all across the world and surviving. And so what about changing, improving practice when you have these very disruptive technologies in a good way that change the trajectory and actually add complexity to the problem? And could you paint a picture of what it's going to look like in 10 years for clinicians, med students in practice now or training now?
Yeah, I think that what's great now is the technology of informatics and information and data. We are going to get much more data. The problem will be we'll have too much data, and how do we decipher the good data from the bad data? But we're going to have a lot more data rather than just hearsay and guessing and so forth. And I suspect as we go forward, we will be much more data-driven in what we do, which will allow us to kind of get to that green bar in science, in organizations, and so forth. So I think that is a huge boon that we're going to face, and a great thing we're going to face in the next 5 to 10 years.
So maybe streamline the front end.
Yeah.
So it happens in real time more than the extreme planning and so forth.
Right.
Fantastic. So as we close, I would love to give you this a token of our appreciation of your work and sharing your work with us in a way that I believe was very accessible and exciting and triggered a lot of discussion. So thank you so much.
Great. Well, thank you. Great.